Did you know that the strength in which enamel binds to dentine at the DJ is approximately 50 megapascals? So when we're looking at the literature for which adhesive system or which bonding agent we should be using, do we actually need more than 50 megapascals? A lot of adhesive systems will easily give you 20 megapascals. Is that good enough? It probably is. We know that adhesive dentistry in the right environment done skillfully can work, and sometimes all you're achieving is 10 to 20 megapascals. However, if there are a few things that you could do in your practice, in your protocols, to reach the higher ends 50 and even beyond, then perhaps we should consider and learn these techniques. For me, it depends on how complicated it makes your procedure. Like if it becomes really technique sensitive so that only 10% of the time you're getting 70 megapascals and then 80% of the time you're getting like 10 megapascals, that's not predictable. That's not a predictable way of doing it. So how can we make our bonding protocols more predictable so we get the higher bond strengths more consistently? That's what today's episode is about, because I asked Dr. Sam Sherif which is the best adhesive system, which is the best bonding agent, and to tell us which generation or generations of bonding agents should we be buying. Hello Protrusive, I'm Jaz Gulati, and welcome back to your favorite dental podcast. Today is a very geeky one. We go into science behind the bonding, and I love how Sam will break down the different generations, which we've all come across, the different generations of bonding systems, and we fell asleep in that lecture, and there's just far too many generations, but actually we make it clinically relevant. And I love that he actually gives you sound advice on which generations to avoid and which generations to go for and which bonding agents he believes in and what the literature is saying. If you're a new listener, welcome to Protrusive. It's great to have you. If you're a returning listener or watcher on YouTube or on the Protrusive Guidance app, it is so great to have you back. You've picked a good one to re-engage back into. Very clinical relevant in our daily dentistry. And towards the end of the episode, we'll actually cover little nuances and how we can actually get the higher bond strengths. This episode is eligible for CPD. There will also be premium notes, which get released in the Protrusive Vault of Protrusive Guidance app, which you should totally download on iOS or Android. The Protrusive Dental Pearl I have for you is to read the instructions for whichever adhesive system you're using. Now, I've said this before, but some cool things that I learned here is that in some adhesive systems and some bonding agents, if you aerobrade the dentine, something I do routinely, you are actually hindering your bond strength. Whereas with other systems, you really enhance the bond strength by using air particle abrasion. So if, like me, you're just blanketly air abrading everything, then we need to reconsider. It kind of depends. Is that compatible with your adhesive system? So I would just pause, even if you've done this before, but it's been a few years, I would just pick up the literature again, find the literature, ideally independent if you can. And Sammy does reference a really cool paper, this group that releases a paper every 10 years, looking at how to optimize bond strength. So I will add that paper to the Protrusive Vault. But the main lesson is to really use whichever adhesive system you're using in the way that the manufacturer intended, and only really deviating from that or enhancing that if some evidence base suggests that actually by tweaking this protocol, you could get a better result. But essentially, don't make it up as you go along. Please don't just etch for random number of time and just using it in a way that the material was not designed to. Hope you enjoy this very geeky episode, and I'll catch you in the outro. Dr. Sam Sherif, someone who every time I see the word adhesive dentistry, biomet dentistry, you come to mind. My friend Niall always raves on about you and your knowledge and wisdom, and I've been following your stuff online for a while now. Welcome to the show. How are you?
Thank you very much, Jaz. I'm glad to be here. I've been, excited to get on your show. It's something I listen to going to work each week. So thank you for having me on.
Amazing. Well, I think the kind of stuff we're covering tonight is absolutely, I think, fundamental, because we're there at dent school learning about these adhesive systems, bonding agents, and the generations and stuff for an exam. But I think what I'm really excited to pick from you is actually the real world application of it, as well as actually answering these niggling questions that, which generation actually is the best, and how long will this continue for? Will it go into like generation 50 and 60 and that kind of stuff? And it'd be interesting to see how close you think we are to the pinnacle of bonding and the little nuances. So it's going to be a very geeky episode, I feel. And I think that's going to be a fun one for all the Protrusive to listen to. For those people who haven't heard of you, haven't seen your stuff, please tell us about yourself, where you work, what kind of stuff you're into.
Yeah, I'm a prosthodontist and I work in Harley Street. I came back from America about 12 years ago. After I finished up at Guy's, I went over there, I did pros, and I did a PhD at Harvard Med School. And then it was a choice of either staying in Boston as faculty or going to LA, and I got a very nice offer in Beverly Hills. So I went over there. and, stayed out there for a few years. I ended up buying that chap's practice. But I think in the end, the lure of Europe for Europeans is too much with the easy travel. So came back.
I mean, what a location history, right? That's very impressive. In Beverly Hills, did you ever come across Lane Ochi?
Yeah, and another great prosthodontist. Yeah, came across Lane.
He is such a great guy. I'm a huge fan of Lane. So great. I didn't know you practiced in Beverly Hills. Oh, amazing. And then now you're in the heart of London. Man, that is quite a career trajectory. How much do you think, this is completely like random, not like in my list of questions, but your PhD, I didn't know you did a PhD, so you're a proper doctor. When you were doing your PhD, how was it, like super academic or was it clinical?
My PhD was on the academic side. So to graduate, you have to do your residency. So you choose your specialty and you either pick a 3-year master's or a 5-year doctorate. The doctorate I did it in was a lot to do with implants and the bacteria around implants. So you'd order the bacteria, you'd grow the bacteria, you'd run the DNA hybridizations. So that was fun. But overall, the program, would be very clinical, but also very research, because we'd do, 8 till 6 in the clinic, and then you'd have research time or classes at night. And then you do your lab work like all good pros residents.
Do you have a life? Like when you're like, that sounds so intense. Do you have a life? I mean, people who do masters and MCLIN dents and that kind of stuff, they always tell me that you literally have no life. But did you experience that as well?
So we were all jealous of the endo residents, because the endo residents would Wednesday afternoon go off, moonlight, do some work. Saturdays they would do that. The pros residents would be doing the lab work, casting, designing, and then we'd have classes. And I think you take it for granted, but I spoke to a lot of people here, perio residents, and we'd have famous perio residents Monday, Tuesday night for perio faculty. Just come and give us tutorials to 3 pros residents, 3 perio residents in the first year. So I would say those were the best years of my life, even though they weren't much of a life. You were locked in there, and you tend to live about a 2-minute walk from the dental school, because that is going to be your life for 5 years.
Amazing. How did you get into, in terms of, you could go, like you do everything. You're a prosthodontist, your research and PhD and implant focus and the bacteria around that. But your what you teach on and what you put out there is a lot of biometric adhesive dentistry. And they make sense now why I know some of the courses you run go very deep into literature as well. So it's starting to all make sense to me now. How did you get attracted to that particular part of dentistry?
It was 2005, and Harvard had an exchange with Switzerland, and Urs Belzer, who was Manier's mentor, came over for a sabbatical for 6 months. And the book had just come out 2 years before. So he signed it for all of us. Mm-hmm. And it was kind of a mind switch that we started preparing onlays under rubber dams. And you can imagine in pros, when you're doing 26 teeth, 28 teeth, there aren't usually a lot of rubber dams. We'd be bonding everything under rubber dams. And it was from Belzer that it started, that we had Belzer in the clinic. And Belzer is a tutorial for 6 months. And then, they sent some of their people, I guess, to Minnesota, which was Manier. They sent some of their people to Harvard. And so we got faculty from them. And it just developed. And I like the accuracy and the intricacy. And it's a cookbook approach. You have to follow 1, 2, 3 and do it accurately. I think all of us in dentistry maybe are, nerds with a little more personality, or engineers with a tiny bit more to us, but we like that geekiness of knowing what we're doing is the right thing for patients.
Okay, that I didn't know that. How you see all these things I'm learning about you as well. So what an influence from Urs Belzer. That kind of, again, you can't connect the dots looking forward. You can connect them looking back. And I always like to inquire about my guests. Why do they go into that particular niche and stuff? So that's great. So you're in a great position then to answer about the different bonding agents, sort of adhesive systems. So they go from the first generation, second generation. How do you feel about for the students who are listening and maybe revising for exams, and actually the real world wet-fingered dentists out there on their commutes thinking, do I really need to know about the different generations? Well, whether you do or don't, it'd be nice to have a little overview. So Sam, could you just enlighten us about the different generations? What are the different nuances between them?
Sure. If we go over the first 3 very quickly, because no one really uses them, but first generations came around in the early 50s. These had a problem of high shrinkage and very low bond strengths, 2 to 3 megapascals. Now, for reference for everyone, enamel bonds to dentine are just over 50 megapascals, so 2 to 3 is nothing. Okay. The second gen came around in the late 60s. They couldn't get a strong bond to the calcium that was in the smear layer. And these had about 5 to 6 megapascals. Again, not great, similar to glass ionomer to dentine. Okay. Third generation, took another 15, 20 years, came around in the mid 80s. This was the first time they tried to deal with the smear layer with very weak acids, and they were worried about pulpal inflammation. So what happened was that the bonding to dentine was very weak. So we really start to, get into the game with the fourth generations. These came around in the mid-1990s, and this is the three-step total etch technique. So if we divide it for the listeners, you're either etching to condition the surface, or you're aerobrading, or you're doing nothing. So for fourth and fifth generation, you're acid etching. For the sixth generation onwards, there's no, acid, so there's no rinsing. It's just going with a primer, and those are different primers. So fourth generation, it would really be a three-step. So you'd have an acid etch, okay, and this, by this time, became phosphoric acid. And the founder of this was Professor Fusuyama. He's a famous guy, found caries detecting dye as well. So a lot of things happened over at Tokyo Medical and Dental University. This was in 79, around the same time he found caries detector. And what he found was that if he uses phosphoric acid, and the percentage now is agreed upon as 37.5%, but it was going between 30 and 50. And if you go up to 50, you get too many of the salts coming out of the tooth. You'll see it comes very chalky. So we've got the 37.5. And then he had a two-bottle system. And in the two-bottle system, he had hydrophilic monomers, which are dissolved in organic solvents. Now, these solvents, they are super volatile. And because they're volatile, they displace the water from the tubules. And that's what we want to do. We want to push it out. So the acid etch in step one exposes the collagen network, exposes the intertubular dentine, and then we get resin tags formed. And then another chap from over there, Nakabayashi, in 84, termed this the hybrid layer, which we all know about now. So you can see how it starts to fit together. Now, if we talk about nuances, we said we want to have wet bonding, okay? We don't want to over-dry the tooth.
This was for fourth generation that they were advocating wet bonding, right?
Exactly. So if we over-dry it, the water is removed, okay? And the collagen fibrils collapse. I want people to think about it in their mind like the carpet or a rug at home when you hoover it. And then when you walk on it, you can see the footprints. If you imagine if you over-dry the collagen fibrils now that they're etched, they just collapse like a rug or a carpet when it's walked upon. Now, the water formed the function of a plasticizer. Plasticizer means it just holds something up. Obviously not a direct analogy, but when water plumps up chickens, things like that. So it plumps up the collagen. When it plumps it up, it's more available for the primer and then the bond to infiltrate. Okay. Mm-hmm. We don't want it too wet because our bond is hydrophobic. So what we need is some hydrophilic monomers to go in there to chase out the water, but still plasticize or leave these collagen fibrils upstanding. Okay. And what they found is that a great one to do that would be alcohol. And that is the agent that's in Optibond FL, which is the main fourth generation that everybody knows about. So then what happens is that these plasticizers allow deeper penetration. Kanker in 92 was the one who coined the term wet bonding. So if you over-dry, I want them to think of it as Swiss cheese, what the collagen looks like. You really shrink everything, all the dentine. It shrinks the volume available for penetration by about 65%. So if you re-wet it, the area that the primer can get into becomes a lot more available. So it's not a carpet that's crisscrossed anymore. It's not Swiss cheese where the holes are very small. Everything's a lot bigger. We can get a lot more penetration. The other thing that we have to be careful of, though, in fourth generation is because we're etching, we're actually removing what's called the Whitlockite crystals that are in the tubules. Whitlockite is calcium and phosphate. If you imagine when tooth gets decay, MMPs jump into action and they act to try and defend the pulp. So what they do is they cause the dissolution of the hydroxyapatite around the tubule. And they form a little plug in the tubule. So now no more bacteria or caries front can move towards the pulp. Now this is calcium rich, so it's great to bond to. It also has another function. It doesn't allow fluid to the pulp or bacteria to the pulp. It doesn't allow fluid to come up to the developing hybrid layer from the pulp. So in teeth that are vital, that have a pulp, we have to be careful because if we're going to remove this plug, we're going to risk getting water underneath the hybrid layer, which isn't a good thing. Okay, so that's fourth generation. We'll run over the others quickly. Fifth generation was late 90s.
Just want to ask you about that. So you're teaching about the deep details, which is great, and maybe it's starting to make sense to me now. Where I heard probably from someone who's gone to your course. I think Shida went to your course once, and we were talking, and she was teaching me some stuff. And she said that whilst dentine bonding is, well, in certain schools of thought, it may not be as predictable as enamel bonding. Actually, you can achieve a higher bond strength to dentine than you can to enamel. Is that correct?
That is spot on correct, because you've got to think of dentine as like rope. It's very tensile, means you can pull on it. If you think of enamel, when we do a class 1 and we over etch the enamel and we've got a really good bond on there, and then what do? We go and cure everything. We see these little white cracks in the edge of the enamel because enamel is brittle. And so enamel, you're going to top out in the low 30 megapascals. Remember we said enamel joints to dentine at about 50. With dentine, depending what you do, and we'll talk on the nuances of treatment, with OptiBond FL, etc., you can get between 59 and 74 megapascals with however you treat the primer. So dentine is a lot stronger. So, we all got asked in school what's stronger. Everyone thought enamel, but it's really dentine.
And is it something to do with this calcium-rich plug that's formed in the tubules? Is that partly responsible, we think, or not really?
Well, that's one of the things. If you're using a 6th generation or a Self Etch, maintains the calcium. But even with OptiBond FL, what's happening is a dentine bond develops a lot slower than an enamel bond. Your enamel bond, within a minute, is mostly developed. So by the time you've cured it, and that's when the clock starts ticking, and start packing your composite in, the enamel bond is almost there. The dentine bond takes time, okay? So we know that, at about half an hour, it's 95% formed, but it will take 5 days to be 100% formed. Obviously, we're not going to wait half an hour. We're not going to wait 5 days. But it's a case of doing small layers, letting it develop. The analogy I'd give you is at home or in your office when you want to hang a clothes hook up. You clean the wall, you put it on the wall, and then you don't go and hang your coat straight away. It says leave it for half an hour, etc. That bond is developing in the adhesive against your wall the same way the bond is developing at the hybrid layer.
Mm-hmm. Okay. Brilliant. Well, I think is that same thing as decoupling with time, right?
That is decoupling with time. Yep.
Okay, perfect. It's all coming back to me now. So hat tip to Shida, our mutual friend, for teaching me some things from osmosis. So please tell me, you're on 5th generation.
Generations. These came around in the late 90s, and this was a simplified approach to the 4th generation. Because 4th generation suffered some issues that was very technique sensitive. So what they said is, we're going to have acid etch still, because acid etch gets rid of all the smear layer, gets rid of all the contaminants. It gives us a surface to have micromechanical bonding. But let's make it easy. Let's put everything in one bottle. Now, you can imagine when you put chemistry that's hydrophilic primer and a hydrophobic bond in one bottle, they don't like each other. They want to fight. So what happens is you don't get as much penetration with the primer, and then you have to air thin it. And whenever you air thin, you introduce oxygen. So you get an oxygen inhibited layer. So you may start blowing it with the 3-in-1. You may introduce oxygen at the dentine adhesive interface. So then you've got no bond there, and you'll get an adhesive failure. You may introduce oxygen between the layers of the adhesive. So you'll have a cohesive failure in the bond. So we don't want oxygen. We don't want this oxygen inhibited layer there.
I never even considered that as a molecular possibility, but obviously it makes sense. But I never even considered air thinning would introduce oxygen. It makes sense now, but yeah, I definitely hadn't considered that.
And then when you look at the instructions, some of the instructions will tell you to do that. But when you think it out and you read papers, you don't want oxygen. You don't want to air thin this. What you want to do is...
So is it better to use this high volume suction?
Use the high volume suction. And if you've got excess, you can wick it away with a clean micro brush. So these had lower bond strengths, and they suffered similar problems because they weren't correctly used of sensitivity. And you can tell this as well because, whether the nurse puts it in the Dapkins dish or she puts it on the back of your glove, the 5th generation, the 7th generation, the ones that are going to run down to your watch because they're not filled, they're a lot thinner. And this has other problems that we can chat about when it comes to the nuances of the gold standard bonding agents. So then if we move to the 6th generation, so 4th and 6th are where you want to be structured in your bonding agent. 6th generation example would be SE Bond 2. These are self-etching by their name, primers, and it's a 2-bottle system again. So we have the hydrophilic chemistry in the primer. We've got weak acids, hydrogen ions in the primer, and we've got a hydrophobic bond. And the idea here is we're going to attach to those calcium ions. So we don't have micromechanical bonding. What we have here is ionic bonding, which is very strong. Okay, there's not a lot of difference between this and OptiBond FL. Now, the big plus is that it's not as technique sensitive as 4th generation. because we don't have the drying issue. The other advantage of it perhaps is that we treat the surface with air abrasion. So if you treat the surface of dentine with air abrasion, and this is a paper by Van Meerbeek, his group in Belgium put a paper out every 10 years on all the bonding systems. Your bond on dentine will go from 37 megapascals with SE12 to 54 megapascals by air abrading. Because when you're air abrading, what you're doing is compacting the smear layer. If we think about what acid etch does, acid etch gets rid of the smear layer problem because it just dissolves it strong enough. Okay, the weak acids, which are hydrogen ions in the self-etching systems, are not strong enough. So if we don't compact that smear layer with a form of treatment, and the best way of doing it is with air abrasion, we're going to get a much weaker bond. Okay, so really,
and with the air abrasion, I mean, are there some adhesive systems that perhaps you would hinder their bond strengths by air abrading?
Indeed, this is a very, very good point. If you go back to OptiBond FL, and Van Meerbeek's shown this, if you air abrade with OptiBond FL, you're going to drop your bond strength 10%. So he drops the bond strength to 54 from 59 just by air abrading, because that's relying on having, no smear layer there. So it's system specific. Now, let's say somebody in their practice doesn't have an air abrasion system, whether it's a fancy AquaCare or a 200-pound Danville machine. What they can do with the surface treatment of 6 generations is use a very fine diamond and use it like it's in a slow speed. It's going to be obviously in the high speed, but you're just polishing. You're not trying to cut. And what this will do is compact that layer as much as possible. You won't get up to the 54 megapascals, but you're still going to be better than any other system other than 4th generation.
Okay, that's a top tip right there for those, because it's a common question I get from Protrusive. I don't have an air abrasion unit. What can I do? Well, there's your answer, guys. Use a fine burr for a 6th gen and run over it. So that's gonna help us to get better bond strengths.
And so then if we start to finish up the generations, so 6th generation also was something important when SE Bond came out, which was MDP. So MDP is great because it helps us bond more reliably to dentine, and MDP is used to bond to zirconias, if we follow the Marcus Blatt's articles from 2013 onwards. So what you see when that patent ran out in 2012, 2013, was a slew of other companies that were now able to incorporate MDP. If we go to the 7th generation, these came out between 2002 and early 2005. These were a single step Self Etch. So they had the weak hydrogen ions, they had the hydrophilic primer and the hydrophobic bond all in one bottle. So we can imagine the bond strength was going to be very low in these adhesives. 8th generation came out 2010, and this was Voco Future Bond. Okay, this was better than the 7th generation because it had nanofiller in it. These nanofillers are about 12 microns in size, and what they could do is they could penetrate into the tubules better. Okay, when they penetrate better, we get stronger bonds, and they also had a longer shelf life than the 7th generations. Okay, so when we're looking at what to use, gold standard would be 4th and 6th, okay, because these ones have got the research on them. They're a lot thicker, and we can go through that. I wouldn't recommend a single bottle system, but if someone said, I really need it in my clinic, what can I use? You have to play around with it, and there's nuances of making 2 layers to get IDS, but I'd probably go with an 8th generation over a 7th generation or a 5th generation if I was limited to one bottle. But I think, we're not in that much of a rush that we need to skip out, maybe 20 seconds of priming and 20 seconds drying.
Can you give us some examples of which other brands of 8th generations are there?
8th generations, what you'll have the 3M Scotch Bond, okay? Mm-hmm. If that's a good one to talk about. If we look at the chemistry that's in that one bottle, we've got weak hydrogen ions, which, approximately around pH 2.8. So they're not strong enough to etch enamel, okay? So whenever you don't etch enamel, what's going to happen is that you're going to get staining down the line. So that may not be an issue for you, on an occlusal on an upper 7. But probably if you're doing, a lower 4 on a shorter patient and they're going to see that staining, it's going to be a problem. You've got the hydrophilic primer, the hydrophobic bond, but this is where the big problem comes in because they started putting silanes in there and MDP. Now, silane needs to exist at pH 5.5. So we've just said that the hydrogen ions are at 2.8. So what's happening? We have an ineffective hydrogen ion that's not etching the way it should. And we've got a denatured silane component, which is also a problem. Whenever you have silane that's on its own and it's not a 2-bottle system, silane's going to have a much shorter shelf life as well. So you really got to be on top of what's in your bottle. before you use it for different applications.
So checking the expiry date, basically, to make sure, so it's a shorter expiry dates.
Exactly.
And a G Premier bond?
This one's promising. It's got some, good research out there with the G Premier bond. So this is one I'm actually excited to look at, what comes out of it. They say you never want to be the first by which something's tried, but the last by which it's set aside. So I'll give it a little time, but that's one.
Being honest, the reason we're using it is because that's what my principals and we all decided that, okay, this is a good system for us. And so I've been using it for a few years, but it's difficult to say. And my data and my colleagues' data work in a practice, what we need is to look at the actual data from clinical trials. But having said that, how many of these adhesive systems actually have clinical trials? Because there are these benchtop studies, which we get some information from. It's better than just producing a bond without any data, obviously, about how they're bonding to extracted teeth and stuff. But in research, it's very difficult to actually apply that because there's so many other different factors. Their occlusion could be different, their muscles could be different, their quality of enamel and dentine, the caries removal could be different. And that's why it's difficult to get that kind of data. Is there anything you can add to this sort of conversation about getting data for what's actually clinically going to be good rather than what's going to be good in the labs?
What I would say is you've hit the nail on the head that it's very hard to get it. An example would be the depth of dentine that you're in. If there was sclerotic dentine, which is more mineralized, that will give a higher bond strength. So it would be an unfair test. What they've done in some of these tests is they've done the restoration and then they've extracted them from vivo and then done the bench tests. I would go with the concept of the more bond strength you've got on a bench top, the more it's going to be better for life. Because when you chew on it, you lose 10% of bond strength immediately. Okay. So if you have a non-gold standard adhesive, so non-gold standard would be one that's not OptiBond FL, not SE Bond 2, you're already probably in the 20 megapascals. Okay. And that's if you're in the superficial dentine. As soon as you get down into deep dentine, depending on your protocols, if you do everything with the protocol as it says, you probably lose 25% of the strength, the research shows. If you don't do it with the protocols and you start layering too quickly, you lose 50%. So we're already at the low teens. And then we know that you're going to lose 10% of it as soon as the patient bites on it. So there's aging of the bond. So I would prefer to go with a bond that has these bond strengths in the 40s, 50s, 60s, rather than the ones that are in the 20s on a bench top.
Brilliant. I think that's a nice overview of the different adhesive systems. When will it stop? It will never stop, right? Innovation will always continue. I mean, we're on generation 9 now. Is that right?
Yeah, we're out there now. I think obviously commercial aspects come into play, and it's quite natural for someone to think, the iPhone 15 is better than the iPhone 10. Okay. And the same if you think generations, that generation 9 is going to be better than generation 4. If we're looking, is OptiBond FL still the gold standard? And is it still predictable? I go back to the research. If anyone wants to look at the Van Meerbeek papers that come out of the Catholic University of Leuven in Belgium, he puts them out every 10 years. He looks at everything. He's independent, so it's not paid for by a certain company. What he shows is that you've got two big ones, which is SE Bond 2, your 6th generation. You've got your OptiBond FL. A close third would be All Bond. But the main two, Bisco. Yep. The main two are those. And there's reasons for it. If you look at OptiBond FL, it's filled. That's what the F stands for. It's light cured. Okay. So it's 48% filled. It's radiopaque and it's very viscous. So if you put it on your glove, it doesn't run. And that tells us something. One, we're going to get a more uniform layer than with a very thin one that feels like water, like a 5th generation.
I think G Premier is like a 4 micron thickness, I think. Something like that. It's very, very thin.
They're thin. The OptiBond FL is 80 microns, and that's on a flat surface. So you've got to be careful because the OptiBond FL is really, it's 48% flowable composite in there. So one of the things to do is really shake that bottle as soon as you pick it up. Other things with it are that it mimics the modulus of elasticity of deep dentine, OptiBond FL, with this 80 micron there. But here's one of the reasons I like it, and I'm not stuck to one system. The oxygen inhibited layer that we spoke about is about 30 microns. Okay, so that means the top 30 microns of your composite doesn't cure. Not a problem with composite because you'll put glycerin or you'll polish it away. But imagine that you have an adhesive that's 20 microns thick or 4 microns thick. That's not curing. So OptiBond FL is 80 microns. Okay, so we've got 50 microns below it minimum. Okay, the other thing to look at is When you come back 2 weeks later at the IDS to reactivate it, how do we reactivate it? We use air abrasion. Okay?
Aerobrasion. Hmm.
Air abrasion, research says, can remove about 15 microns of
Hmm.
adhesive.
Hmm.
So again, let's say we even had a thicker one, a quality one. Let's say we had SE Bond 2, which I like. It's 40 microns. So if we've lost 30 and we haven't taken precautions, which we can discuss, we're down to 10. When we come to reactivate, we're on dentine. So when you look at some of the studies out there, they say IDS doesn't work, people get post-op sensitivity. It's because they've got exposed dentine or the hybrid layer hasn't been cured. So that's the other advantage of having a thick IDS layer if you're doing it for that. Or if you're just using it for your composite, it's the advantage of having a material that mimics that deep dentine, how it flexes. So the tooth gradually gets stiffer as it gets to the cusps.
What do you use? And do you change what you use depending on if it's an aesthetic case versus a posterior case?
Yeah, I'd give a very general rule. If it's direct dentistry, by that I mean class 1s, class 2s, class 5s, a deep cavity, I'll use SE12. Reason for that is SE12, as it's not as technique sensitive. The chance of post-op sensitivity is not there because we've got these Whitlockite crystals blocking the tubules. So there's no transport to and from the pulp. We also won't get these water trees that come up underneath the hybrid layer with water moving from the pulp and that start to disturb the hybrid layer. So that's my direct dentistry. Now, let's say I have a root canal treated tooth and it's come back from the endodontist. That's probably going to have had Miltons all over the place. And Miltons, if we think about it, is a bleach. And how do we denature dentine? We pour bleach on it. If we want to denature enamel, we put acid on it. So we've already denatured the dentine. So we're not going to bond well to denatured dentine. So I want to clear all that off. So I'll refreshen all of the dentine with a rough diamond burr. And then what I want to do is acid etch it to get that damaged collagen away. So I'm not going to get any sensitivity. By definition, the tooth is dead. I'm not going to get any water movement from the pulp because the pulp is left in the endodontist's office. If I'm doing veneers, I'll have to use Optibond FL because if we're removing 0.3 to 0.7 millimeters, depending what we need, we don't have room to put a resin coating on of clear flowable. So our protection for our hybrid layer, for our oxygen inhibited layer, not to have an effect on the bond, is the 80 microns of Optibond FL. And what I'd probably do is I'd put 2 layers of Optibond FL on a veneer prep. If I'm doing...
This is like IDS for your veneer prep, basically, right?
Yes, for the veneer prep. If I'm doing, I don't do ortho, but if someone's bonding brackets or bonding attachments, whether it be Invisalign or any of the other competitors, the bond strength that you're going to get with SE12, it's going to be 22 megapascal with its Self Etch system. If you air abrade, you'll get 26. And this is research from 2003 by Murik. If you use Optibond FL and you acid etch, you're up to low 30s already. So that's a sizable difference. So if you're finding that your attachments are breaking off, maybe you can use the acid etch and the Optibond FL and increase that bond strength, substantially on enamel. But dentine, that there isn't really a statistically significant difference between the 54 microtensile bond strength megapascals we get with SE Bond 2 and the 59 we get with Optibond FL.
Well, it's a nice guideline of direct. You're doing SE Bond 2, indirect Optibond FL for the reasons mentioned. I was at a Marco Gresnitz's lecture, probably said his name wrong, and just fascinating data about the benefits of IDS for the veneer preps and how stable that is and how much better your bond strengths are. So that's very promising, and I'm glad that you've echoed that as well. So it's discussed the different bonding generations. You've made a nice, clear recommendation that 4th and 6th is kind of where you want to be, but watch out for the future. Optibond FL is probably still up there as the gold standard, along with SE Bond 2 as an alternative. And I know what your approved list is. So now I've got 2 things to explore with you. So top tips in actually maximizing the bond strength. You've already mentioned a few, like shaking that bottle, right? You've already mentioned about air abrasion. But the interesting thing, which I didn't appreciate, is actually air abrade according to the adhesive system that you're using. And that was interesting to know that, okay, certain systems you may be hindering by using air abrasion. What other tips could you share for those dentists listening out there who are driving into work that they're going to use today to just get those a few extra megapascals and just serve their patients better?
Perfect. So if we go from the start, let's compare the Optibond FL and the SE Bond 2. So if you've got the Optibond FL, what you want to do as soon as you've finished taking the caries, you don't want to finish taking the caries with your steel burr or whatever, because that's going to be more of a polished surface. You want to roughen that surface so it's very wavy and it's replicating almost a DJ. So I'll get a coarse burr out. Burr I like to use is the round burr 014 burrs. So it's a round burr you're never going to perforate, easy to go at high speed, get caries out, but it's also rough. So that's tip one. Okay, so think of it, you've got to treat the surface of that dentine before you move ahead and start putting etch on. Then what I'll do is...
Can I ask actually again, I'm going to interject and ask here. So there was this concept of etching and bonding that for adhesive dentistry, you want a nice smooth surface. Is that referring to enamel? You want nice smooth enamel to etch, but dentine, you want rough dentine to work with. Is that a good way to think about it?
Again, it's system dependent. If you're using something with an acid etch, which is going to clear that smear layer away, you want the surface to be rough and wavy because we're going to rely on micromechanical. If we're going to have a self-etching primer, we want as smooth as we can get. So again, it's horses for courses. And, I think we've all been guilty of it at dental school. Whatever the nurse passes us, we treat it in the same way. And we're not
absolutely. I'm sure this episode already has been revelatory for dentists. Like, oh, hang on a minute. I didn't know I wasn't supposed to be aerobraiding for this. I'm sure there's been lots of aha moments already. So that's very, very fascinating.
Yeah. So if we look at Optibond FL, we're going to etch the enamel for 30 seconds. And that's the recommendations of Brecci, of Manier, of Van Meerbeek. And we're going to etch the regular dentine for no more than 15 seconds. If we've got sclerotic dentine, as we said earlier, it's more mineralized and the tubules may be closed. So we want to go 20 to 25 seconds on the sclerotic dentine. So it's kind of nice. We're becoming more like scientists when we're in there instead of just, which we've all done, painting the stuff all over the place. And it doesn't become as much of an investigation. Then what we're going to do, we're going to rinse it for at least 15 seconds. And what I say is 15 seconds plus another 5 seconds after you see the last bit of the color of the acid etch disappear up the high volume suction, because it can still linger and have an effect. Step 4 would be don't over dry it. You want to leave the dentine looking shiny. That's the best way I can describe it. And the good way to do that is I go in at 90 degrees. So let's say we're doing a lower left 6. I'll go in from the lingual side and with my 3-in-1, and I'll get the nurse to use the saliva ejector at 90 degrees as well. And we're just going to dry that off because I don't want to over dry the dentine. Okay. Then we come to the primer. Again, if we use an Optibond FL, we want to shake the primer well. If you look at some of the research Manu came out in the JPD with the Brazilian group, he talked about having unidose.
I was there at the lecture and BACD where he was talking about that actually.
So he published it in the end. There'd been a lot of talk about it and it was unpublished data for a few years. In the unpublished data, he said he was getting up to 74 megapascals of bond strength versus 59. I think in the paper it came to about 71 or 72. So what he does is, if you think that when you've got a bottle, that bottle, probably the day you open it, before there's been evaporation, because there's alcohol in there, is a lot better if you're that patient than the patient that's getting it 6 months later, or depending how much dentistry you do, and the shelf life a year later. Okay. So with these unidose, they're almost like rockets. Okay. If you kind of remember what in school, the Optibond Solo rockets would come in where you twist it and it was all in one. So in the study, they heated for 15 minutes the primer to 68 degrees. Okay. And what they found is this caused more activation, more penetration, and higher bond strengths. Now, the trick is, Manu will use the term massage the dentine as you prime it. My tip to people listening was you can't overprime dentine. It doesn't matter how many layers you put, but I'd put at least 2. Okay. So what's happening is it has to be an active process. You have to be gently moving that primer into the dentine. Now, if you've etched the enamel, you don't want to be scrubbing vigorously, because if you nick the edge of the enamel, that enamel is weaker because it's had acid etch on it and you may be breaking off prisms. Okay. So you've got to be careful with the edge of the micro brush. Once I've got the primer where I want it to be with however many layers, again, I'll go at 90 degrees and do the negative suction or negative drying. Instead of putting force on that exposed collagen, I'll use the saliva ejector and my 3-in-1, and it's just a gentle flow over the tooth. If you think like in an operating theatre, a laminar flow, the air's just going one way. Then what we'll have as the 6th point would be to place the adhesive now. Okay, and I tend to switch to a smaller micro brush for the adhesive. The adhesive is very thick. As I said, I don't want it to pool in corners. Okay, which also means I don't want it to be on the edges, or if you think the inclines. If, on a class 2, if you think of the gingival box where it goes up, I don't want it to be thin where it goes over a corner. So I'll manipulate it with the micro brush. Now, the good thing with Optibond FL is radio opaque. So if it's thick, nobody will think you left caries. We'll come to a nuance of SE Bond 2 because that's radiolucent. So you have to write in the notes so that, 3 years down the line, nobody thinks you left a blanket of decay there. And then we'll cure this. What I may do with the curing, depending how close I am to the pulp, a nuance with this, I may do 3 seconds of cure, back off for a little bit with the light, come back, because, if you hold a light cure to your skin, you won't be able to hold it that long, never mind to a pulp. So I'll probably take the light curing in stages, we'll cure it, and then we will be ready. If we're going to place the next layer of composite, we're ready. If we're going to do the IDS, I'll tell you this is the nuance. With polyethers, you get adherences. So the Optibond FL will stick to the polyether, and you'll see this on the impression where you get tears or you get a little bit of purple left on the prep. Okay, so different ways to get around this. I wouldn't advise using alcohol because that removes the unreacted monomers, so you won't be able to reactivate them for the IDS procedure. Okay, you can prophy them or you can cure it under glycerin, one of these two. If we look at the steps in SE Bond 2 to try and maximize your bond strength, okay, with SE Bond 2, we're going to aerobrade for 10 seconds from 10 millimeters away off angle. So I'll normally say at 45 degrees because, again, we don't want to be angling right down the tubules. And for this, you want to be using something around the range of 27 to 30 microns. And it's aluminium oxide that we would use this, or you can use the new ones, which, like the Silka and these ones.
Yeah, they're very promising. But how do you feel about Cojet?
Again, I try and keep it straightforward what's on research. So I'll use the aluminium oxide. And, having spoken with Aquacare, they've given me the silk to try. But I use aluminium oxide. I think theirs is 29 microns. That's what I'll be using with, but no more than 10 seconds for this. After this, I'll rinse it. We don't have to worry how we dry it, as opposed to the 4th generation, which again, that's the first step where it's not technique sensitive. Then this is a difference when you use the primer. The primer has water as its carrier versus alcohol in Optibond FL. So you're going to have to gently massage them in for 20 seconds still, but you're going to have to dry the SE Bond 2 for 20 seconds because it's water, whereas it's only 10 seconds for the alcohol-based Optibond FL. So we've got to dry this. Again, if it's not an active process of placing the primer, if it's just putting it on and waiting, that's not activating the monomers. So another tip would be, it does have to be gentle agitation for the full 20 seconds. We'll dry it in the same way with negative drying, negative suction. And then what we're going to do is place our adhesive. We're going to find the adhesive is a lot thinner, but I'm still only going to place 1 layer. I'm not going to be tempted to place 2 because the adhesive in thicker layers can be weaker. And also it's going to show on the radiograph as a larger black line because it's not filled, okay, which is the problem. Now, this is going to need to be reinforced because it's not thick enough to deal with the oxygen inhibited layer. You're going to have 0.5 millimeters of a flowable, and that flowable should have a low shrinkage. So some of the flowables that work would be a Majesty Flow or Voco Flow, because these ones shrink about 1.9%, which is low. A lot of flowables will shrink around 3%. If you imagine you've got this hybrid layer developing, and then you put something on it which is 0.5 millimeters, which is huge in comparison to 40 microns, and it shrinks at quite a rate, it's going to rip off the hybrid layer. Next tip would be, as we said, you want to wait before you get thicker than 1.5 millimeters. So what I will tend to do is I will take, about 5 or 10 minutes to place my first millimeter of composite, maybe place the matrix band, light cure it, just so that first layer, like the hook on the wall, has had time to develop. And then we'll go from there. Now, the nuance with these is that PVS material, it doesn't adhere, but it's inhibited by the free monomers in these. So again, if this is our final layer, what we have to do is cure it under glycerin. We have to pumice it to get an accurate impression. If I can add something
Yes.
actually.
Yeah. Hmm.
Then when it comes to SE-Bond 2, as we said, the acids will etch enamel, but you will get staining down the line. Okay, so this wouldn't be good for an aesthetic case. So the way that I would deal with that is that once I've sealed the dentine with that 0.5 millimeters of resin on top of my adhesive layer, I'll refresh the enamel in case any adhesive went onto it. And then what I will do is I'll etch it once more, and there's no harm to etching again if it's in an accurate defined zone. And again, that's research from Bresci. And I'll place adhesive just there. Now, the reason for this is with the 6th generation, we're relying on calcium. If we get acid past the DJ, which even under a microscope is going to happen as accurate as we are and as stiff as that acid etch is, we're going to lose 25% of our bond strength if we get any acid past the DJ. So if I have everything sealed, I know I'm not going to get sensitivity and I'm going to maintain my bond strength. It just means I have to spend a couple more minutes refreshing the enamel, placing the adhesive again. And that's how I would do it with SE-Bond 2 if you want to be aesthetic and maintain all the tips to get as high a bond strength as you can.
And I think the great point you made there, which is a reminder, is I've read before where if you are going to etch your dentine, then you will significantly reduce the bond strength using certain systems. But some people think that, oh, you should never etch dentine, but it really depends on which system you're using. So for certain systems, it is a good thing to etch dentine. In other systems, it is going to have like a SE-Bond 2. You're going to have a negative effect on the bond strength by using it. So really got to go deep into literature on how to use the system that you have, right?
Yep, definitely. And I think that makes us, again, it makes dentistry more interesting. It turns something mundane, like a class 2, which, you probably fret most about getting the contact point, something interesting, because you're going to go through every step from caries removal, crack removal, the adhesive that you're using, how you're treating the surface, how you're layering it. And then you can have the fun with your anatomy. But I think sometimes we put the horse before the cart. We're bothered about the anatomy and we don't know what's going on below it. And then we get these failures. So I would say if we have a restoration fail under 5 years, we can't really blame the patient for not flossing or he got recurrent decay. That's us and our bonding protocol that's failed.
And certainly whenever I'm doing even just the humble class 2, I like just visualizing, what each component is doing in my mind. I'm seeing all these tubules, resin tags and stuff. So like I said, instead of just looking at the time thinking, okay, what time's lunch kind of thing, you're involved in the artistic, you're in the nuances, you're under magnification. I just think it brings a bit more joy to our day to trying to get, try and do the best adhesive protocol that you can do every time where possible. So I think it actually enhances our work. Speaking of work, I'm a big fan of your work, Sammy. Please tell us about how we can learn more from you. I know you do teaching in London, probably around the world as well. Where is the best place to learn more about all the things that you teach? And I think it's rubber dam that you do, adhesive dentistry in general. Tell us about the full flavor of what you offer.
So our course is called Get Bonded, Stay Bonded, and you can find that either in the Facebook group. You can come and post your questions. You can just peruse and watch, or you can actually get involved. Or you can go on the website getbondedstaybonded.com. Now the courses that we run from what we do every day, which is basically diagnosing what a tooth needs, removing the caries, the cracks, learning about these adhesives that we've talked about. And that's the level 1. So we do 3 of those a year, and they're always somewhere nice. So we do the Dorchester Hotel, Park Lane, we do the Intercontinental Park Lane, or we do somewhere fun. We've done Anfield up in Liverpool, we've done St. James's Park in Newcastle, we've done Villa Park. So we'll tend to take it up north once a year, and then the rest will be in London. And then we have done some in other countries. Level 2 takes us into, is probably 90% hands-on. This is how to do the 3 types of onlay preps with the 5 types of interproximal margins, how to do semi-direct composites, how to do beautiful posterior composites, and how to use the ribond in the wall, the Del Pieri technique. So this is on typodonts. It's all small group settings, so we get a lot of one-to-one together. Okay, and that's a 2-day course. Level 1 is a 1-day course, and that's on a Saturday, level 1. Level 2s are on a Friday and Saturday. And then we do once a year the level 3. Now, the level 3 is fun because me as a prosthodontist, I do a lot of bigger cases. But this kind of dentistry, when you feel the dentistry and feel you know what you're doing more, it's more fun, okay? But the level 3 is all about treatment planning and occlusion. So I like to give dentists a cookbook approach so we know what to do in steps. So we will learn how to treatment plan the class 2 Div 1 patient on models, the Class 2 Div 2, the Class 3 patient, how to treat them. And this will all be in ceramic, not composites, and the anterior open bite patient. So we'll talk about how to cross-mount models, how to diagnose, how to come up with sequencing. And this is a 3-day course. This is in December. We do this each year. And I don't know if you know Dr. Ash from America, Dr. Ash Lifts. She's big out there.
Of course.
I get her over. Yeah.
Oh, brilliant.
So I get her to come over. She's involved in that. And Dr. German Dorgan, who has been
Herman.
Yeah. So these are the ones. Some we've had rubber dam, we've had photography before, but we'd be happy to see anyone, to help them just enjoy their dentistry more, get it more predictable. And I think when you do the small things like we're talking, choosing adhesives, you become more confident with the bigger things. Like, you know that I can do a tabletop onlay and it won't come off. I know I can do a veneer and it'll stay bonded. So it just makes people's work, and life a little bit more interesting when they have that confidence in what they're doing.
Definitely. When you have that clinical backing and the knowledge that you should get on courses, then you get to apply it, lifts your confidence, lifts the level of treatment you can offer and how you can serve our patients, what it's ultimately about. And I think I've heard great things about your courses, both from Shida, who I used to work with at Richmond, and also Niall, one of the Protrusive who always raves on about your courses. And I've already had Herman and Ash on the show as well, so completing the 3 with you. So Sam, thanks for discussing all these adhesive systems and giving your little nuances and top tips. I've had a lot of moments like, wow, okay, I didn't know that, or I didn't know this, and I'm going to read up more about this. So it's always about inspiring people to do their due diligence and look up how can we get 1% better each day. And you've definitely helped us be several percentage points better today. So thanks so much for your time. And I'll put the links to your courses in the show notes so everyone can check out all this wonderful stuff you're doing. I appreciate you coming on.
Thank you very much, Chess.
Well, there we have it, guys. Thank you so much for listening all the way to the end. Hope you enjoyed that very geeky episode. I know how geeky you guys are, and lots of you will now be going on to the quiz and answering the questions. How do you access this quiz? Okay, so for those of you who are new to Protrusive, you can do this on the laptop. You can go to protrusive.app, the website, and then sign up, and then you can then download the Android iOS app and use your new login to access the app. And on one of our paid plans, you can get access to the CPD or CE quiz. With the Ultimate Education plan, you get access to a whole load more premium content and courses. One of the questions in our quiz today is, which generation of adhesive systems does SE Bond 2 belong to? That's which generation of adhesive systems does SE Bond 2 belong to? Do you remember? If you do, it's an easy way to get CPD, because let's face it, if you've reached this part of the episode, you probably usually listen to the end anyway, so you might as well rack up those CPD points throughout the year as you're listening to Protrusive. Our CPD Queen Marie will send you the weekly certificates and every quarterly, which no other education provider does. We'll send you quarterly certificates and an annual summary of all the education you've done with us. So I want to thank Marie. I also want to thank my producer, Erica, as well as the wider team in Chriselle, Nav, Emma, and Jan. And one more thing before you go about your daily life. Could you just, wherever you're watching or listening from, hit that subscribe button. If you're watching on Protrusive Guidance, then please share this with someone. Tell someone about Protrusive Guidance. I'd love to get the best collection of the geekiest and nicest dentists together in the world. Thanks so much, and I'll catch you same time, same place next week. Bye for now.